If you could begin just by telling me your name and why it is you think I might be interviewing you for this. What's your specialty?
My name is Paula Johnson, and I'm a cardiologist here at Brigham and Women's Hospital. I'm also an outcomes researcher, and I do research having to do with access to cardiology care, predominantly for minorities and women.
Mm-hmm. So we were talking about the scope of the problem of cardiovascular disease among African Americans. Could you talk a little bit about that? Because I don't think a lot of people really understand the size of the problem.
Oh, it's really immense. Cardiovascular disease in our population in general is the #1 cause of mortality. But what we know for African Americans is that not only do we die in greater numbers proportionately, but we also die at younger ages. So for the African American population, especially women, and I think the data are pretty compelling, that at some of the young age groups, in the 30s, for example, and 40s, the death rates for black women are 2.5 to 3 times that of white women. And for men, it's also greater, not quite, the disparity isn't quite as great, but it's significantly greater for African American men as well. And what's interesting is, a number of studies have been done to figure out, well, gee, is it socioeconomic status? Is it risk factors? It's probably some combination, but no one can really explain away the total difference by looking at those factors, so that we can't fully explain that very significant disparity.
Mm-hmm. Could you talk maybe, a lot of people always talk in terms of percentages,
Mm-hmm.
and I find it's easier for me to grasp if you, I don't know, maybe if you could take a group of 10 people or a group of 50 people, and is it possible to talk about the disparities?
In that way, I couldn't give you those numbers right off the top of my head to describe it to you in that way.
That's okay.
Yeah.
That's fine.
Yeah.
We're kind of jumping down to the bottom of my questions here, but I just recently I saw that article about the study that...
right, from New England Medical Center.
Yeah, which is just amazing to me that when you have a group of people that have, people say that they have a higher risk, and yet they're being treated for cardiovascular disease at a fewer rate, they're being diagnosed. Could you talk a little bit about
this is one in a long line of studies that have really consistently shown the same thing over and over again, and we've still not yet really been able to get at the real root of the problem. Basically beginning probably around 11 years ago, that was when the first really good data started coming out about these disparities in treatment. And the first studies were really done on administrative data. And what I mean by that are kind of chart review type of data you can get from, files that Medicare uses. And what we've seen over those kind of ensuing 10 years are more and more data, including my own, that really show that African Americans are diagnosed less frequently when they have signs and symptoms that really point towards heart disease. We see in this study that the diagnosis of heart attack is not made at the same rate when it would be appropriate to make it. We don't know all the intimate details, but it sure points in a certain direction. There are data to suggest that there may be underutilization of cardiology procedures in African Americans who have a very high risk factor, great number of risk factors. There was a study published about 1.5 years ago by a physician named Schulman that looked at scenarios in which actors basically presented all with the same symptoms. So they basically gave the same history, talked about having the same symptoms, etc. And physicians who viewed these videos were far less likely to refer African American patients for further testing. And that was even, the disparity once again was greatest for African American women. So, I think that we've we've now seen probably a little over 10 years of these data. They all point towards the same thing. And we have not, I think, faced some of the hard reality that there's probably bias in the way that we treat patients. And how do we begin to understand that? And how do we begin to understand it in a way that leads us to changing behavior? And I think we just haven't gotten there.
And I've noted that this is one of your specialties.
Yeah.
Could you talk a little bit about maybe what is being done, or what if nothing else, what you're thinking about?
Well, we are trying to basically understand some of the components of decision making around, how when a patient comes to the hospital and is admitted with a certain set of symptoms, how is the decision making made? How does it happen? How does it happen that a physician and a patient work together to come to a certain decision? And is there something in that decision-making process that goes on that leads to African Americans being undertreated or treated differently than their white counterparts? And one hypothesis has been for quite a while that African Americans tend to be less risk-taking. So, for example, if you're going to undergo a risky cardiac test or procedure, that an African American would be less likely to do that than a Caucasian person. And we've done research that show that in fact is not the case. That if you walk in and basically you're an African American with the same number of risk factors, kind of a certain set of signs and symptoms, that you're just as likely to agree or take a risk with a procedure than a Caucasian counterpart. So that's not so much changing a behavior, but it's beginning to try to dispel a myth. The myth that blacks will not agree to certain procedures. Now, does that say that there isn't some increased level of mistrust in the African American population? No, it doesn't say that. And I think what we have to understand is, what is the process of care like for African Americans? How do African Americans get in the door? When they get in the door, who's taking care of them? Do they have somebody advocating for them? Are their families listened to? Are their families participating in the decision making? How does it happen? And I think that if you talk to other physicians, especially physicians of color, that you would begin to, I think, understand that people do see differences, some systematic differences in the way that minority patients may be treated. And I'm not saying this in that people are doing this purposefully, but this is part of our culture. It's part of our heritage. It's part of who we are as a country. And it's, why would it be any different in medicine than anywhere else? So, it's our responsibility to begin to address it in a very serious way. There are places that are beginning to do this. The whole movement in culturally competent care, for example, is one in which, tries to get at how do we communicate with patients of different backgrounds. But I do think until we really face, kind of stop putting euphemistic terminology on it and face the hard facts of what we need to possibly admit and think about, I don't think we're really going to get at the root of the problem without making those realizations. And we're getting more and more data from patients, patient satisfaction data, that kind of once again clue us into some of these problems. African American patients in some places not feeling as though they are as well integrated into the decision-making process. Families not being included at the same, or not being included in a way that they feel they should be. And so I think that we're not only recognizing that and hypothesizing around that, but we're hearing it from our patients. And that isn't even to talk about the patients who never even get to access the system, which is another whole group of people that we're talking about, the people who manage to walk in the door. We aren't even talking about those who haven't even gotten to the door.
Mm-hmm. Yeah, and it's interesting because it seems that this is talking directly to institutional racism, and that it isn't necessarily something that people do consciously. could you talk maybe just, it's such a huge subject, because we've got, it seems there's also, from other people that I've interviewed, there's a certain amount of lack of trust in the African American community because the people in the hospitals don't look like them, they're not, the doctors don't look like them, they're not being treated by people that, either they've been let down so many times by projects that have come into the community and tried to help and failed for whatever reason. I know I've opened up a large area here to talk about, but maybe we could start with that trust issue. Do you think that there's a trust issue between African American community and?
Yes, I mean, I think that there is a trust issue. I think that, you know, historically there have been any number of reasons why African Americans would not necessarily trust large academic institutions or any healthcare institution. I mean, you know, for many years, African Americans were denied access to healthcare institutions. That led to a segregated system, and there have been many things inflicted on the black community. And you know, obviously, people would bring up Tuskegee as the biggest example, probably the most prominent and well-known example. But there are examples like that run throughout. Kind of run throughout the system. We now have safeguards against that type of activity, clearly, but that's the type of thing that doesn't die easily in terms of trust. And I do think that the majority of institutions, especially large academic institutions, do not have significant numbers of minority faculty, minority nurses. So the professional staff does not reflect frequently the community. And if you look at where the majority of large academic institutions are, they tend to be in communities of color. So in fact, they don't represent or reflect their community. Now, many places are working on this, as we are, but it's a slow process. It's one that takes a change in culture. It's kind of a process that is evolving. But it is a difficult, I think, situation for patients when they do come in and they don't see people who look like themselves and who may or may not understand then kind of culturally what is expected.
It's interesting with Tuskegee and other things because we're only talking about a generation ago.
Yeah, it's not that, it's not that long ago. And I think that there are, many preconceived notions about minority health and minorities' ability to intervene in his or her own risk factors, and I think that once again, those are the kinds of attitudes, kind of those deep, they're somewhat silent, but those held attitudes and beliefs that translate very likely into a difference in care.
This is such a big topic. When we get into the medical side of it, I'm surprised since I've been working on this project for about a year and a half, and made a lot of calls and did a lot of research, and have been surprised at how few people really understand the scope of this problem in the medical community, and how many doctors and researchers, people I've talked with, that aren't really that aware of all the research and everything that's going on, which astounds me because it's happening at the biggest, most prestigious universities in the country. Any ideas or thoughts on how this is not being recognized, how it's not getting out there? What do you think has this been, first of all, has this been your experience?
It's not been my experience because I think that I'm at an institution where we've really focused on this as a research question, so that I think that many people here are aware of the research. In terms of your perception outside, I would say that people probably pay attention to what interests them, and that you hear and filter in a way, once again, that speaks to your own needs and beliefs. That would be that would be at least a stab at what you're perceiving, because to say that this has not been in the newspaper, it's not even as though it has only been in research journals and the premier research journals, but it's also been prominent in the media. So that if you do have, let's just say, cardiologists who are unaware of this issue, then it speaks to not hearing it, and not hearing it in a way that, once again, speaks to the problem. Speaks to the problem of not addressing it, not understanding, and it not being even within your scope of recognizing your connection to the problem. So the fact that you've spoken with many people who are not aware of the research, to me, is part and parcel of why we continue to find the same thing over and over again. Now, it's very interesting because concurrent with a lot of the research on African Americans has been research on women. And you had almost a parallel track of data being presented about women and underutilization possibly of procedures in women and lack of access in women, et cetera. And it's what's very interesting is that the more recent data that we've seen really speaks to the fact that that gap is closing. And in some areas, in fact, has been closed. And my own data support that as well. So in a way, the information was presented for a gender-specific group, and it was heard. And in some way, not necessarily with specific programs, but in some way through advocacy, possibly through programs, and through a heightened awareness, some of that difference has now resolved. We've not seen that in the African American population. The same thing has not happened. There's not been the same voice. There's not been the same advocacy. And within the female group, black women are still out there with the race group of being African American. They're not getting equal treatment. So when I say gender and women, I'm specifically talking about Caucasian women.
It seems to me that there's still, again, it's just from talking with people and now outside the medical community, that when I talk about the issue of racism relating to cardiovascular disease, most people say, well, kind of almost like, isn't it African Americans' own fault? With the diet, with the lifestyles and other things, as well as heredity and everything else. Which says to me, okay, that's a fundamentally racist belief. That's a statement right there that's racist from people that don't even consider themselves racist. Where does lifestyle fit in? Where does all this stuff fit? I know that there still needs to be a lot of research and everything yet to be done, but how do you react to that? Because it does seem to be there's a fairly common consensus that I've run across.
Right. Well, lifestyle is important, but do blacks develop hypertension earlier in life and end up with worse, end-stage renal disease and worse heart disease because they don't take their medicine? I don't think so. Could that be some small part of it? Well, maybe there are issues around access to care and ability to get your medicines. But I think what you're fundamentally hearing is that it's the African Americans' fault, and if they really wanted to be rid of the disease, they could do it, because they could do any number of things to improve their lifestyle, and decrease their risk. I think we have no idea. I think we believe that, and data from actually from the Nurses' Health Study, which comes out of this hospital, does show that very possibly by changing lifestyle, eating healthy, exercising, et cetera, that you could probably, decrease the number of cases of cardiovascular disease by, 80% or so. Have we tested that? No. And what about the other aspects of African American life that make those changes very difficult? Not that somebody doesn't want to. Initiative has frequently nothing to do with the reality of the life circumstance. So I think that frequently we don't put the person in the entire picture of what their life circumstance is and what they and help people and work with them to basically use what their current resources are in order to help them make the lifestyle changes that they may need to make. That takes working with people. It doesn't take dictating to people. It takes working with people. It takes understanding where people are coming from. It takes understanding where people are living. It takes understanding what their socioeconomic status is and understanding what they can and can't afford. Exercise for, a suburban housewife who can play tennis many times a week is very different than for someone who lives in in an urban environment where it may not in fact be safe to take long walks outside. So when we say walk at least a half an hour at least 5 times a week, well, for some populations that may not be that easy. And how do you then work with people to kind of work in an environment that's their reality? And we don't do a very good job at that. The other thing I think we have to talk about in terms of you brought up the issue about racism and what role does racism play. Well, it's a very hard thing to quantitate. But I'll tell you something that we do know. We know that, and this research also came out of this institution, we know that when a person has coronary disease and you put a catheter in their coronary artery that has blockages, and you give them difficult math problem, so you're causing some kind of mental stress. We know that you cause those arteries to constrict. Now, if you translate that, now this hasn't been tested, but if you translate that then into a situation in which an African American may be dealing with any number of issues around subtle and sometimes not so subtle racism, what is the daily stress level around that? And what's happening to that person's coronary arteries every time they are confronted or are coping with some of these issues? Very hard, because we're not going to have people walking around with catheters in their arteries. But on the other hand, it to me is a model that I use to kind of translate what we talk about as not being measurable into something that may be then a little bit more understandable in terms of what damage racism can possibly play in people with coronary disease. And we don't know what the effect is in terms of people with risk factors who don't have known coronary disease but on the development. I think it's a totally unknown area.
It seems that there almost needs to be a certain amount of common sense applied to this issue, because you can't have a control group. You can't have African Americans in this country that aren't exposed to racism every day of their lives for their whole life. So I don't know how one would even do a scientific study that would, because unless I'm wrong, I can't imagine there's any way.
Well, I think it would be very interesting, because there probably are ways, probably in the not too distant future, there will be ways to non-invasively, on a more continuous basis, measure kind of reactivity of the vasculature of the arteries. And if we were able to do that, and we were able to get a cohort of blacks with risk factors and a cohort of whites, we may in fact be able to understand, well, gee, during any given day, what is going on in the vasculature in these two groups of patients. I mean, that's kind of a quick and dirty example, but I think that there probably will be ways to not directly measure racism, but to measure the impact of stressful lifestyle on different populations.
Because there have been certain studies about like A-type personalities and stress, and there have been some pretty clear connections between that and cardiovascular disease. Right.
And and it's not just it's racism, but it's also issues around life circumstance once again, and knowing what the life circumstances for African Americans as well as for other minority populations, there is a certain amount of inherent stress involved. Not that everyone walking around today, or at least to some degree, is living with stress, because I think everyone is, or almost everyone is. But I think that there may be some issues that clearly disproportionately affect our minority communities.
And talking with a lot of people too, it's not even just specific outright racism, but suspected racism also has an effect. I interviewed Camara Jones, and she was saying, pointing to me, you have the option of saying, well, that bus driver is just having a bad day. I don't have that choice. I mean, to me, I always have to suspect. So I think this is something that a lot of white Americans don't really understand, is that it's not even just the fact that it's out there, but it's also all of what's inside from all those years of training has to also add tremendously to the stress and to the experience of racism for African Americans.
Right. No, I think it does.
Yeah. I tend to go on and on.
No, that's
sorry.
fine. That's fine.
Let's see if we get back on. It is something that I've talked with some people about too, and it has to do somewhat with African Americans don't feel empowered when they go to the doctor, or in terms of managing their own health care. Do you have any experience with that, or can you?
I don't personally. I think that there has been a body, once again, of information building around this issue of information sharing and what creates an environment in which patients do feel empowered. And once again, that's a two-way street. So that I think you tend to be more open, possibly, and sharing of information, possibly with people who are like you, and who you connect with at some level. And if you think about, once again, the African American or any minority community being different from the majority, one could easily see how that connection and that sharing may not occur at the same level. So the challenge becomes, once again, that two-way street. How do you really enable providers of care to be more open, sharing, sensitive to their patients' needs, and facilitating of that relationship?
Sorry.
No, that's okay. So we were talking about, it is that two-way street, and it's getting the providers of care to be more sensitive to the needs of the patients who are not like them, who they may not naturally connect with, and to better understand their needs. But it's also a matter of really working with patients to really enable them to get the kind of knowledge and understanding they need to have to ask the right questions, to really be able to, once again, be advocates for their own health and their own health care. And that is that there are a number of activities going on around that, in terms of really empowering the patient to be more actively involved and doing it with information, but not necessarily information in the way that we tend to give health information, which is either in a brochure or but how does that information transfer happen most appropriately for different groups? How do you really work with different populations to address disease in a way that they see the disease, and not necessarily in the way that a majority person would necessarily see the disease. So, for example, we tend to treat, especially in the subspecialties, we tend to treat.
Go ahead.
Okay, we tend to treat the specific entity. So for heart disease, we'll treat the heart attack, and we'll continue to treat kind of maybe the risk factors that go along with it, but in a with a very narrow focus. And in minority communities, that may not really be the most appropriate model. I mean, the more appropriate model may really be a more holistic one, in which the entire person and their needs are really addressed. So I think that once again, we have to get out of our traditional model of care, because it may not work for everybody. And this becomes more and more important because more and more of our patient population is non-majority. So it's not just a luxury anymore, it's not a side activity, it should be one of our central focuses.
That's great. Just wait to see if that telephone will stop.
Oh, let's try to. Okay.
Do we need like a medical equivalent of affirmative action? I mean, is there something that needs to happen with the in the medical community here that is a more active? Well, I guess there is, but an even more active approach somewhere where it's really out there and people are saying.
Well, I think that there does need to be a significant amount of advocacy around this, and I don't think in order to achieve what we need to achieve, it's not just going to be the medical community. It's going to be essentially, it being recognized as a major public health issue, and there needs to be the kind of awareness and advocacy around it that probably has some grassroots activity as well, in order to make this kind of a real significant priority. Usually, at least in my experience, that's kind of to get it to the top of the list or to get it as a priority. Usually it takes people in power recognizing it as a significant problem and making it a priority. And I think we need to do that here. The question is how. In terms of women's health as a model, and I'm not saying things are perfect there, but there was very significant advocacy in any number of areas. There was grassroots advocacy. There was advocacy from the healthcare institutions. There was also governmental advocacy. We had a head of NIH at that time who was a very strong proponent. I think to address, and it's not just heart disease, it's any number of diseases for our minority communities, we really need the same level of advocacy to raise awareness and to bring it high up on the priority, list.
Yeah, it's interesting because that's been one of the responses that I've gotten from time to time is, not being an African American, why am I interested in this issue? And I've said, until we realize that this is an American problem, it won't be dealt with.
Right.
This is not an African American problem or a white problem. I mean, this is an American issue. Could you speak about that? I mean, is this an African American problem, an American problem, a social problem?
Well, how did we end up here? And we didn't end up here because of African Americans or because of other minority populations. We ended up here because we are who we are, as I said earlier, as a nation. And we're a nation made up of many people. The vast majority of people who hold the power in the United States are Caucasian. So yes, this is an American problem. And it is one that requires the attention of a multitude of people of all colors. And the solution is really going to require the collaboration of a multitude of people. Because, as I said, our healthcare institutions are not minority. And in order to change things, we're really going to need a shift in how we view the care of our minority populations, and we need to mainstream that issue and not marginalize it.
That's great. It's we just any other specific tools that you could talk I know. I think we're just going to have to live with it.
It's okay. It's one of the power issues here, but it's all right. I'm moving
Oh, okay.
up to the executive suite, so you know.
Yeah, no.
You know, herein lies the problem, okay? I'd love to see my coronary arteries right now, okay?
We're talking about maybe specific tools that African Americans can use to deal with racism, deal with racism in institutional racism or anything. Any other specific tools or anything else that you could say on that?
You know, I think that, you know, that African Americans need, just like any other, and you know, I do want to include other minority populations in this because I think that it is just as critical for other groups as well, and that is to really feel empowered to really be able to make choices. You know, no matter what kind of insurance they have, they do have the ability, you know, and sometimes it is limited, but they do have the ability to change care providers, to really look for what suits their needs. And I think, you know, sometimes going with your gut about what feels right, what doesn't feel right, is frequently a very good test of whether or not you're getting what you need. You know, do you feel comfortable in terms of the communication style? Do you feel cut off? Do you feel that your needs and your family's needs are being considered when talking about therapies? And you know, I'm only talking here about a very small slice of healthcare because once again, I'm talking about those people who are accessing the healthcare system. But I think recognizing kind of what you do have control over is a very important thing. And then really trying to get as much information if you are, you know, if you have a set of symptoms that you're worried about, you know, to try to get as much information as possible, not only from your healthcare providers, talk to your friends, you know, talk to those who are around you. You know, if you're a person who goes to church, talk to the people in your church. Begin to share information and experiences, because I think that sometimes those are some of the most positive educational experiences and can really help people begin to validate what they've been feeling. And to also get some good information. And I think that, you know, that's one place to start. You know, unfortunately, you know, the numbers of minority households who have computers is not that high. Hopefully in the future that will change. The internet has become a tremendous resource in terms of healthcare information. Now, you know, that's a mixed bag because some of it's good, some of it is bad. But, you know, these days they're, you know, in libraries, you know, if you are not able to use a computer, you can frequently go to your local library and have a librarian help you look up information. Ask your physician, what is a reasonable site for me to go to if I have heart disease? You know, the American Heart Association has an amazing website with all kinds of patient information. But these are the kinds of things that I think we need as a community to begin thinking about. How do we educate ourselves so that we can get what we need?
If you could imagine a magic wand, or you know, what would you visualize for the future, or for if you could just change everything, what would your vision be?
Oh, that would be so, you know, it goes so far beyond healthcare because it really, you know, it has to do fundamentally with inequality in our society. And, you know, I think probably in the 1960s, although it was a turbulent time, I think there was the optimism that at some point that the kind of inequality that existed would be gone. I think in the year 2000, we're probably much more cynical about that. You know, I do have a child, and I always hope that for him, no doubt, things are better for me than they were for my parents, than they were for my grandparents, etc. But that for him, that some of the issues that are out there in society, that he would not have to deal with them. I don't have much hope for that because I don't necessarily see the focus. I don't see the advocacy. I don't see the importance being placed on it. If I had my way, I think that we'd live in a very different world. And it would be reflected not only in our country, but it would be reflected across the globe.
Great. Yeah, it's interesting. I posed the same question to Cornel West maybe a month ago or so. And he also, I am surprised, and I think maybe a lot of people in the audience will be surprised too, that there is a certain amount of cynicism. And as you said, it seems things were going along at such a rapid rate, and then what happened?
It got hard.
Mm-hmm. Yeah.
Segregation was, I'm not saying it was easy, but it was a target. It was a very clear target. You can get a target. And I think there was general agreement, at least amongst the majority, that this is something that's wrong. It's very different when you begin to deal with other issues and problems that are more institutionalized, that are part of our day-to-day living, that would take really, that would be a threat to many in our society, to really change that. And it's got to be a priority, and it's got to be a huge will. And I just don't think there's a huge will. The economy's booming. Why change it? And I think that's really, therein lies part of the problem.
Yeah. Well, my last question is always, if you were sitting here interviewing yourself, would there be something that you'd ask that I haven't?
One thing that we didn't talk about was, well, no, we did. That's fine. I was going to say we didn't talk that much about the kind of relation of race and class, because there have been a number of people who have said, who've made the argument that, once you move into a different socioeconomic group, that the problems are no longer there. That it's really only a certain group that we're looking at. And I think that once again, the reason why I said I'd mentioned it earlier, that the data really speak to the fact that despite whatever socioeconomic group you belong to, race is an independent predictor of those poor outcomes and of risk factor burden. I mean, it gets a little bit better, but it's not dependent on socioeconomic class. So I just think once again.
One more time? I'm just.
Oh, when I okay.
Well, that's very important.
Yeah. The question as to whether or not race is really a proxy for socioeconomic class, and whether it's really the socioeconomic class issue that we're looking at and not really race. And I think that data have shown that yes, there is some interaction between the two, but race is really a very strong independent predictor of outcome in heart disease, as well as in a number of other diseases, as well as a predictor of access to care. So, it's not just the economic class. It really is race as a very important factor.
So almost no matter what socioeconomic class.
Right. I mean, it does get better. It does get better as you move up the scale. But each group is fraught with their own issues. And now I'm not going to remember the name of the person who actually wrote. Is it Ellis? He's a journalist. He wrote the Rage of the. What was the name of the book? The Rage of the Middle. The Rage. It's a book about. I know you're not doing this, but it's a book about. You should actually read this, because I think that it would be very. Elliot Coase. That's who it is. Elliot Coase. And it's called The Rage of the Black. It's either The Rage of the Black Middle Class or something like that, but Rage is in the title. And essentially it's about kind of the perils of dealing with race in the middle and upper middle income African American group. And it's an area that has not necessarily been that well explored, and he was really one of the first people to write more extensively on it. But what are the stressors that occur for African Americans, even as they move up the socioeconomic ladder, and what is life like? And it's really worth reading.
Well, it's interesting. I mean, it was a few months ago with his name just slipped out of my head. The actor Danny Glover in New York. I don't know if you
Oh,
talk
I know.
about somebody
Yeah.
who was wealthy, recognizable, couldn't get a cab.
Yeah.
He sued. I mean,
Yeah.
he's in the midst of legal proceedings.
Oh, I saw that in the news. I think that's been in the newspaper. It's been in the Times.
That's what we-
Yeah, and I think that those are the kinds of things that happen, I mean, I can remember, when my husband is Jewish, and I can remember thinking when we were looking at our houses, to buy a house, I remember thinking, kind of talking to people on the phone, always knowing that people don't necessarily think I'm black, and thinking, kind of recognizing that I was actually thinking about what people would think when they actually saw me. And I think it's something, once again, it just speaks to the fact that it's an ever-present force. You're constantly thinking about it, even when you don't think you're thinking about it. And it's not that you're obsessed with it, it's just what life is like.
It's always there.
Yeah.
Great. Unless
So,
you have
okay.
anything
Nope,
which-
that's good.
Terrific.
Thank you.
Wonderful.
Yeah, thank you.